Now that we've discussed bone and ligament injuries, let's move on to tendon issues. Quervains Tenosynovitis is an overuse tendinopathy of the abductor pollicis longus and extensor pollicis brevis tendons at the base of the thumb on the radial aspect of the wrist. This is the most common wrist tendinitis and can occur from any repetitive wrist or thumb activity. So in theory, almost any sport, but most commonly in rowing and racket sports. It's also common in the postpartum period from lifting a baby repeatedly. Pain here is at the first extensor compartment, as demonstrated in the picture. There may also be local swelling or crepitus. In the Finkelstein test, the patient flexes the thumb across the palm, and then the wrist is stretched into ulnar deviation. This will stretch the affected tendons and reproduce the pain. If you have all of these findings, then you can diagnose it clinically. An ultrasound might show thickening and hyperemia of the tendons. Initial treatment involves managing pain and inflammation with a thumb spica splint, anti-inflammatories, stretching, and strengthening. Cortisone injection is useful if the initial treatment isn't effective or if the symptoms are very severe. Surgery is rarely needed, only if symptoms are severe and conservative measures aren't effective. Intersection syndrome causes pain about 4 to 5 centimeters more proximal than Quervains Tenosynovitis, and it occurs where the tendons of the first and second extensor compartments cross. It's also an overuse injury and occurs with repetitive wrist extension and radial deviation. It's common in rowers, weightlifters, football linemen, and skiers. They may have audible or palpable crepitus, which is often described as squeaking, at the site of pain, which is circled in this picture, and that will happen with active wrist flexion and extension. They might also have a positive Finkelstein test, since the first extensor tendons are involved. This is also a clinical diagnosis, but it can be confirmed on ultrasound. Conservative treatment is usually effective, including rest from the aggravating activity, wrist splinting, anti-inflammatories, and potentially modifying sport equipment. For example, changing the size of the oar and/or rowing technique in rowing. Cortisone injection might be needed if it's severe or if they're not improving. Once symptoms resolve, they can gradually return to sport. Surgical decompression is very rarely needed. The second most common wrist tendinopathy, after Quervains, is extensor Carpi Ulnaris, or ECU tendinopathy. It's again an overuse injury from repetitive extension and rapid flexion, ulnar deviation, and supination. It's common in racket sports, especially with a two-handed backhand in tennis, and in rowing, baseball, hockey, and golf. The tendon is easy to palpate along its course, which is seen here in green. It runs dorsally over the TFCC, and tendinitis is sometimes associated with a TFCC injury. It will be painful with resisted wrist extension and with ulnar deviation. Sometimes the subsheath that keeps the tendon in place can rupture and cause subluxation with painful snapping. This is more common in racket sports and contact sports. If that happens, you can usually observe the subluxation in clinic with active extension and supination. This is also a clinical diagnosis, but ultrasound can assess ECU stability, and it can rule out tears. An MRI can show more detail, but may not pick up dynamic subluxation. Treatment is generally conservative, involving splinting, activity modification, anti-inflammatories, active rehab, and modifying technique. For subluxation, immobilization is the first line of treatment, but surgery should be considered if there was an acute injury that led to the subluxation, or in persistent cases that aren't improving. On the palmar or volar aspect of the wrist, Flexor Carpi Ulnaris or FCU tendinopathy can occur with overuse in golf and racket sports. Flexor Carpi radialis or FCR tendinopathy is less common but also possible. The athlete will present with localized pain and tenderness at the affected tendon, which you can see here in the picture showing the palmar aspect of the left wrist. Ultrasound or MRI can confirm the diagnosis or rule out other injuries. Either of these tendinopathies can be treated with modifying activity to prevent recurrent overuse, with splinting, and with active rehab. Now we'll go over a couple of nerve conditions. Carpal tunnel syndrome is compression of the median nerve in the carpal tunnel. It's common in the general population and can also occur in athletes with predisposing factors like hypothyroidism, diabetes, or pregnancy, or with repetitive hand and wrist use. Occasionally, young athletes will get acute Flexor tenosynovitis, which will cause compression of the median nerve and acute carpal tunnel syndrome. The main symptom is numbness and paresthesias in the distribution of median nerve at the radial 3.5 digits, which is shown in pink here. It's usually worse at night or with the aggravating activity. Tinel sign is positive if the symptoms are reproduced with percussion of the median nerve over the carpal tunnel on the palmar aspect of the wrist, which in this picture is where the 4 colors intersect. Phelan sign is positive if the symptoms come on with the patient holding the backs of their hands together in wrist flexion for 60 seconds. In chronic cases or severe nerve compression, there might be thenar wasting or weakness in thumb flexion and opposition. There may also be decreased sensation in the distribution of the median nerve. Usually this is a clinical diagnosis, but ultrasound can show thickening of the median nerve, and electrodiagnostic studies can confirm nerve compression and assess the severity. Most cases will improve with rest from the aggravating activity, wrist splinting, especially at night if the symptoms are nocturnal, and anti-inflammatories. If these aren't effective, then a cortisone injection may help. Surgical release should be considered if there are severe symptoms, atrophy, weakness, or no improvement with conservative treatment. Ulnar nerve compression will produce symptoms on the other side of the hand, at the 5th finger and the ulnar aspect of the 4th finger. It's sometimes called handlebar palsy because it can occur in cyclists with prolonged pressure from the handlebars. In late stages, there may be wasting of the hypothenar muscles. There may also be weakness in grip strength, pincer grasp, and finger abduction and adduction. And there might be decreased sensation in the distribution of the ulnar nerve. Ultrasound and MRI can identify compressive lesions like ganglion cysts or an ulnar artery aneurysm, which can also occur in cyclists. EMG and nerve conduction studies can confirm the diagnosis and assess severity. For mild cases, splinting and anti-inflammatories should help. Cyclists can also adjust their hand positions and/or change the handlebar position, and they may be able to pad the handlebars or wear padded gloves. For severe cases, or with weakness or ongoing symptoms, then surgical decompression may be needed. The last condition that we'll talk about is quite common. A ganglion cyst is a synovial cyst communicating with the joint space. It can happen in just about any joint, but it's very common in the wrist, usually dorsally over the scapholunate ligament, but you can have them on the palmar side of the wrist as well. They can happen with just about any type of overuse. The diagnosis is usually fairly obvious, with a visible and palpable focal swelling that transilluminates and sometimes is tender. It can be sore in positions of compression, like in wrist extension for dorsal ganglion cysts, or flexion for palmar ones. Ultrasound or MRI can confirm the diagnosis, measure the size, and find the origin of cysts. Most of the time, they'll improve with splinting and with rest from the aggravating activity, and with some anti-inflammatories. If they're asymptomatic, then they don't really require any treatment. Large or painful cysts might benefit from aspiration and cortisone injection. For a volar ganglion cyst, this should be referred to a hand and wrist specialist, since they're usually very close to the radial artery and flexor carpi radialis tendon. If the cyst continues to recur, or if it's causing nerve or vessel compression, then it can be resected. That's the end of my talk. Thank you for watching, and here's a list of references.